Hi everybody, Rachel Seward here, Deputy CEO for WACOS. Welcome to the next in our series of seminars on preparedness for COVID-19. I'd like to acknowledge the Whadjuk Noongar people the Whadjuk people of the Noongar Nation, and acknowledge that we are on stolen land and that we have a lot of unfinished business. As I said last week, this is the season of Baru, which is where the summer is at its hottest. And I don't know if people got to see Dr. Richard Wally last night on the ABC News explaining this season. He explained it so eloquently, which once again demonstrates that the Noongar people's deep connection to this land, their deep understanding of the seasons and how much their seasons make so much sense. Today we are continuing, as I just said, our series on preparation for COVID-19, and we'll be talking about business continuity planning, service continuity planning, and we have a series of speakers, including Bev, Joel from Department of Communities, and Elaine Patterson for the Department of Communities, Elise Blay and Deb Zanella from RUA, Sue Budelich and Beth Harvey from Nagala, Kim Brookland, again, who gave such a fantastic presentation last week from Parkerville, and Louise Gelotto from, as we know, the CEO of WACOS, who'll be moderating questions today. I'd like to hand over to Bev from the Department of Communities to welcome, and then Elaine will speak.
Hi everybody, so Bev Joel, I'm the Acting Manager for Strategy and Partnerships in the Sector Support team. It's great to have you all here again on another webinar. We're becoming experts on webinars, although we did start late, our apologies. I too would like to acknowledge the traditional owners of the land on which we meet today, the Noongar people, and just say that we're in the beautiful land of Whadjuk, which is Fremantle. And we also welcome people from other countries this morning to our webinar. So thank you for joining us, and thank you to WACOS for co-hosting these webinars. It's great to be able to provide this type of support to the sector. We know we don't always get webinars perfect, but we're hoping it's just an opportunity to at least get some information out to people. And we're also hoping this webinar will be a little bit more interactive, so there's a bit of an opportunity to do some Q&A. So thank you to all the speakers, really great to have you on board. And I'd just like to quickly introduce Elaine, who's, well, I'll let Elaine tell you who she is. Thanks, Elaine.
Good morning, everyone. Elaine Patterson, I'm the Acting Executive Director of Contracting. And yes, we probably are getting more used to these webinars, although it is very strange sitting in a very big room with a few of us all with masks on. So I'm envying the people who are sitting at home without them at the moment, although I know we all have to get really used to them. I want to kind of say thanks very much everyone for taking the time to attend these. I think they're really important for us to have these conversations and discussions. I think we're all going to have to work together and be as flexible as possible in the months ahead. We know that cases are starting to increase in WA, so it's going to be really important that we continue these conversations, continue the discussions, and we all get pretty solutions focused and try and figure out the best way we can. I've said previously in some of these webinars, I think the focus particularly here for my area, contracting, contract managers, we'll be trying to work with their organisations as much as possible, trying to be as flexible as possible. We recognise some things will have to change. Even this morning, I just saw something came in from an organisation saying they wanted to be more flexible in how they do face-to-face delivery. We're absolutely fine with working with organisations to support that. And we'll be doing as much of that kind of work as we can over the next few months and working with you. The highest priority really for us is to make sure that the services continue, recognising there may be some changes to the type of services. So I can see there'll be instances of we're in really high caseloads where it will be where there's a supported accommodation is probably going to be the highest priority, and we have to make sure vulnerable people in those accommodation services do get the support that they need. So not looking forward, I think we'll all just be working together over the next few months. One of the things we're trying to do just now, we're working with the Department of Finance and with WACOS. We're talking about, is there anything that we can do quickly in the meantime? And we know that the Department of Finance had some masks from last year, so the PPE masks. They're not surgical masks, or sorry, they are surgical masks. They're not the kind of N95, but they are likely to be out of date between, I think it's April and June. So what we're looking to do, our intentions to see how we can work together and get some of them distributed out to the sector, so at least you have some of those in the meantime. Obviously there's kind of going to be quite high demand for masks, but we know they are available, but these are here just now and it's something we can do quickly and get rolled out. So we're trying to do that. Hopefully we'll be able to give you an update on that next week. I know there's a meeting later this afternoon to try and work out some logistics and how that will happen. So happy to keep you posted on those kind of things. And I'm looking forward to the questions and trying to work with you and try and find some solutions as we work through this in the months ahead. So that's all from me. I think we're back to Rachel again. Oh, you're on mute, Rachel.
Thank you. Right, we've got that you're on mute out of the way. Thank you very much, Elaine. That was very useful for people to know, and I'm sure there'll be some further questions around those particular issues. WACOS is really pleased that we can co-host this webinar with the Department of Communities. It's important that we are working very closely with the department as we deal with the issues around preparation for COVID, because evidence from the eastern states is that it's only by working very closely both with government agencies and with our with the rest of the sector that we will ensure that we can deal with this issue the best way possible. Like last week, we're not going to be dealing with issues of RATs and PPE, other than if they pertain to your questions around how it plays into business continuity planning. Again, like we said last week, we are continuing to press government, work with government to try and come up with a solution on those particular issues. It's really important that we put time and preparation into the business continuity planning and service continuity planning. We've seen again from the eastern states how important those plans are, but also how important it is that they are flexible. And we just heard about flexibility, and so organisations are already asking for flexibility. We heard that from Elaine. It is really important that while we have plans, that they are flexible. Again, it's a key learning from the East. Also, to work with our staff to ensure that we are keeping them in the loop and supporting them in what could be in the future some confronting situations. I'll keep my comments short because a few technical glitches means that we're a little bit behind time. So I'd now like to hand over to Elise, Blay and Deb Zanella from RUA to take us through what they have been doing in terms of their business and service continuity planning. Over to you, Elise and Deb.
Thanks, Rachel. Keen to speak today around the process we've gone through over the past months and weeks in preparedness for COVID. I'm going to focus today on our practical approach, which we've been fine-tuning over the past weeks, and this falls as a layer within our BCP, our Business Continuity Plan. So we've done this through adapting the WA Health System Alert and Response Framework to make it fit for us. So that's the SAP framework. And we've seen the need for this as a practical solution that gives our leaders a framework to make decisions in. We've seen with all the change that we've had and the rate at things can change, that we need to have a flexible response that's not too detailed and not too prescriptive. So this has been a huge effort from the teams, and really want to say thank you to everyone who's helped in building this. We've been stress testing the ideas with partners and sectors in the colleagues in the sector, and building on the great work that was presented last week. So thanks so much. We're also keen to share resources after this. So if we go to the first slide there, the alert phase. So this is, building on the SAC framework, we've determined for RUA, what our triggers would be for each phase. So these are beyond WA Health phases, as we see a real potential where RUA goes into a higher alert before the hospitals go into a code brown. With what we've seen from Omicron, people may not be in hospital creating a code brown, but in the community sector we may reach staffing pressures earlier. In this, we've got an org-wide alert and also a service-wide alert. So it may be for us that In mental health, we're in amber, and FDV could be in red. So this would make the entire organisation red in that case, and we'd move the workforce as needed to meet that need. We've had lots of conversations around essential services and which services are more critical than others. So going to the next slide there, we've got service delivery. So across all of our areas of legal, family services, mental health, and housing and homelessness, this covers everyone. So this is an org-wide approach, and within that we've got specific approaches with more detail. This is a tool that looks at, some basic principles like when we go into working from home, what working from home looks like with client visits, PPE, communication and things like that. And within this kind of structure, with the alert levels, we've got kind of subtables looking at, when different leadership groups meet, what team meetings look like, things like that. So through this process, we've had lots of discussions around succession planning, looking at the principles we've decided is moving sideways. So recognising that the teams on the ground need to have it as normal as can be to be able to deliver the service that they do. So we've looked at how can we pull experts in across the services and for the GMs and the leadership team. The discussion in here around what services are most critical and when we'd pull people from one to another is really important, and we've seen that will change. So it may be that, as people are accommodated or as other services shut within the sector, how that looks may be different. So as I said, we've really changed from a specific approach with clear guidelines on what to do in each step, and we've worked towards having something that can provide a guide for people to make decisions, knowing that if it happens tomorrow, people have got guidelines to look at and some principles to work with. So I think in terms of this approach, we're looking at learning from the East and knowing how things can change. So we've got links in there to the live documents, always following WA Health in addition to our organisation's plan. We can go to the next one there for slide 4. So this covers the principles across every stage, from green to black for my service, which is housing and homelessness. Some kind of principles in here that we've got are things like vaccinations are encouraged and promoted for clients, and we're working really hard to do that. But the vaccination status of a client would never be a barrier to them receiving service. So we've got that in there across, all phases, as a reminder for people to go in here and kind of look at the key principles. Another one is that, safety is always a priority above the risk of COVID spread. So we'd never want to put someone at risk, from an aggressive client or in a dangerous situation at the risk, to protect someone from spreading COVID. We've got some guidelines in here around what we might do when we're waiting for SHIC to alert SWIC and advise us on the next steps for when we have our first case. I'm pretty aware that this plan, has got lots of good things in it, but there's still a definite unknown in lots of phases, and how that will play out for our first case. We don't know yet until we see how that works. Just going to slide 5 there. So this is our acute, the acute emergency response for housing and homelessness. This goes alongside the crucial need for prevention of rough sleepers getting COVID, vaccinations, and having somewhere for them to isolate. And we're all working really hard, and there's some brilliant work going on around the clock to look like how we can have this preventative response. So I think, in this, it goes into a bit more detail about what client visits look like. You can see for red there, we've got the, anyone whose mental health, wellbeing, or tenancy is at risk, they'd be considered, crucial for a face-to-face visit. What we know is that when we look at black and we're at capacity, we've been having some really difficult conversations around at what point, if everyone is unwell and isolating, at what point do we stop services? And I think this planning is really crucial to look at being able to work with the unexpected. In here we've got some detail around A and B teams, how engagement hubs in the Safe Nights space will manage, and how we support clients with phone calls, and how we use different people in the workforce. So say the people who are isolating, they do the phone calls first, and then the other people would do the crucial face-to-face visits. The last thing we want is someone to return into homelessness because their workers are moved into another critical role, and then that person becomes critical. So lots of conversations like that we don't have the exact answers to, but we're looking at principles to set that up. We're pretty clear that it won't be a perfect response, but we've done as much work as we can to plan for that. Rachel, please give me a hint if I'm going over time. In terms of the next one is slide 6. That's the outbreak management plan. So in terms of the hierarchy or the architecture of how these documents fall together, we've got our business continuity plan and then those principles, which is the green to black. And the outbreak management plan is adapted from the Department of Health Congregate Living Outbreak Plan. This is a really useful checklist that we've adapted for us. And so this is the first document that the teams would use if there was a case, at 2 o'clock in the day and we hear about someone confirmed in our service. This is a document that they'd work through to fill out. And it's, it's kind of 10 pages or so that you'd fill out what we do in practice, and there's clear instructions there to work through. So the principles is, management for whoever's leading that response. And this is a really practical how-to tool to work through when that happens. And it covers things like making sure we know who was in the service, who was vaccinated. We've got a plan of the building, like a fire exit plan to be able to share with Sheep and Swick, things like that. And then if we go to slide 7, this is, for comms organisation-wide, we've got a COVID hub, which has got, this is a snapshot of kind of PPE tracking and how to use a RAT test, how to use PPE. And this is a page where we've got everything central. We initially had, things in kind of locked away folders, and we've realised that there's nothing confidential in it, and that it's better that everyone's got access in one place for whoever's running the show at the time. If assuming the succession plans needed to be activated, everything's in one place and there's really clear links to all the other documents. We're close to having a dashboard which will have, where we're at in the different phases. So currently we're in amber. It would have, some key highlights of what needs to happen in each phase. So I think that's, oh, yes, Rachel?
I was just going to say, you've got about 2 minutes.
Okay, great. So I think, yeah, that's, that's really the architecture that I was keen to speak to. I think in terms of, those slides are snapshots out of a larger document, which is not perfect, and it still has some highlight in it and some questions in it, but I'm really keen to share it if it's useful for anyone. The work we've done is building on everyone else's work and building on other guidelines that are available. So yeah, keen to share it. And yeah, Deb, have you got anything else to add before we go to questions?
No, not really. I just think there's a lot of detail, but I think the intention of this session is that people can have access to documents that are a bit more detailed for their own internal planning, and we're really happy to share on the caveat that it's not perfect. And I have taken away from Melbourne that some of this stuff will be different depending on where the first positive case is. But I think what I would say as a CEO, what this has done is given particularly the general managers and their next lines down confidence that they have got something that gives them a sense of boundary and parameters about what's the higher order of thinking and decision making. The other thing that Elsie forgot to say is that Mark is the designated COVID controller in our organisation. Elsie is deputy COVID controller. And so that's also on the architectural design. If we get into black phase, Mark is the person who makes calls on service delivery, meeting times, whether we meet, what needs to happen. So there's always one locus of control.
Yeah, sure.
Thank you very much, Elise and Deborah. That's a very comprehensive outline of your plan. What we're doing, if people have questions, can they put them in the chat, and then we'll come to questions at the end. Okay. Thank you very much. I'd now like to invite Sue Budelich, who's the head of operations at Nagala, and Beth Harvey, who's the manager of quality and impact at Nagala, to speak to their approach to how they're developing their business continuity and service continuity planning.
Good morning, everyone, and thanks, Rachel. And can I start by acknowledging the Whadjuk people of the Noongar Nation and pay my respects. And in the true spirit of business continuity, you'll notice that we don't have a video. Because we're so well prepared and we have a plan in place, we can pivot directly to giving you a verbal update. And I echo something that Deb had said as well, which is a nice segue, is we certainly don't profess to be the experts in business continuity, but in the spirit of collaboration and working with our colleagues across the community services sector, we'd really welcome the opportunity to share with everybody what we're doing and how we are preparing for it. We'd also like to acknowledge, in listening to and talking with some of our colleagues, is that we acknowledge that different organisations are on different parts of that continuum in terms of preparation. And it's okay if you're not as well advanced as, let's say, RUA is in other organisations, but the important thing is to start, and everybody's willing to help each other. We're in it together. We, underpinning our approach is really, our planning has been based around what are the knowns. So we don't assume anything. We make sure that we do a real, quite an in-depth facts check, and that we echo what the health directions are. We don't, I mentioned we don't assume, but what we've also got to do is there's a fine line between working to the facts and also anticipating what some of the unknowns are. And that's where I think the business continuity planning comes into effect and is worth its weight in gold. We do have a two-pronged approach, probably not unlike RUA as well. So we've got an organisational response to business continuity. The beauty of that is that it allows for consistency across the organisation. That's certainly important when you're managing any emergency responses, is that there's a level of consistency, and that staff are aware and they know what to do, and that everybody is pretty much heading in the same direction. But also with having an organisational response, it really allows for us to focus in on the communication to our staff as well, so that the information that we give them, there's always that two-way street up and down, and that our communication's timely and it's accurate. We do have Beth, who's pretty much our head honcho when it comes to all things business continuity. So when we move into, like Deb said, when we move into those critical times, we look to Beth, and we also look to our CEO, Fiona. What I'd like to do now in terms of the organisation is hand over to Beth, who can share some of the things that we've done at that organisational level.
Thank you, Sue, and hello everybody. So really, one of the messages I thought would be good to share, and I'm hearing it's a common theme really across, I was at the last week's webinar and heard Kim speak as well, is just around that, talking about fit for purpose. So any planning, any work models, any business continuity plans, risk assessments really need to be flexible, achievable and sustainable. So we've worked really hard, I suppose, with that anticipation, but trying at all times to not overreach and to make sure that whatever we put in place isn't overwhelming for staff, particularly with some of the anxieties I imagine you are all aware of that they're facing out in the service land. We've made sure that all decisions that we make up to this point are risk-based and context to the size, nature, geographic location of the services and our organisation as a whole. We have actually had already some scenarios that in relation to staff who have been either at exposure sites or who have been close contacts or have had children who are close contacts, and we've actually had a positive case, albeit of a staff member, albeit that they were on leave at the time. So the risk to our service was obviously very low, if at all. However, what it allowed us to do was to almost test the processes that we had set up, and we found where we needed to put some continuous improvement elements in place, and also adjust and adapt. And I think that's a big learning for all of us, because until you've had that first opportunity to do that, which sometimes it will be a lot higher risk than what ours was, all these plans are great until they're not. So that's a bit of an information sharing as well. Just following on, again, internal communicate is our theme, particularly to staff and to our clients, and just making sure that we are able to present all of the information in a really, as Sue said, factual and as simple as possible way. We use the infographics that the government have provided, and so on and so forth. So We provide that information in a measured and staged manner, again, so we don't overwhelm staff, and we just want to be responsive to their needs and their queries as well along the way. I really liked what Elsie said about safety first, and I would also say that even in a pandemic, we always have to be aware of other legislative requirements that may impact business continuity, so privacy and obviously financial elements of legislation, lots of different things. So I guess that's just another point. And I think actually that's as much as I've got. So Sue, did I cover that?
Perfect.
Okay. Yeah.
Perfect. Thanks for that. From a service delivery perspective, what I'd like to do is share with you what we're doing when it comes to more of our services and our programs. Once again, not professing to be an expert. We've started to undertake a business continuity analysis. The first thing of that is for, if I backtrack a little bit, the way that Nagala is structured, our services and programs are delivered through 4 different streams. All of those managers report through to me. Together we've come through and I've asked people to undertake their own individual business continuity analysis plans as individual portfolio areas. The first part of that was to ask them to have a look at what are the essential services and what are the non-essential services. And then we'd come back together as a group and have a look at that. The reason that I wanted us to come back as a group, if I use one of our programs, we have a private hospital on board. So if my manager had put that down as a which she never would, but let's say she put it down as a non-essential service, we could turn around and say, well, hang on a minute, that is an essential service, we need that, etc., etc., etc. Whereas one of our programs out in Carnarvon, for example, RESAS, or the Remote School Attendance Service, if the manager had put that down as an essential service, we'd say, well, that doesn't sound like an essential service. Why is it? She'd say, well, we're pretty much the lifeline in the community of Carnarvon. So there's different reasons for it being essential and non-essential. So that was stage 1. Stage 2 is to actually go into the planning side of things, having a 3-pillared approach to that. One is, which we've already got the plans for based on all the lockdowns that we've been through, so very comfortable with that. Then the other 2 is what do we do in the case where there's moderate impact, things that we're going through right now, where we're seeing community transmission occurring, but it's not prevalent. So how do we respond to that? And then the 3rd pillar is almost that, I nearly want to say danger Will Robinson, but that kind of really exacerbates the stuff and could put a fear into people. So from a severe impact, all jokes aside, is when the community transition is prevalent, how do we respond to that? In terms of helping guide what our response to that, I've asked the team to look at it from 2 different perspectives. One is have a look at what the key activities are that might be affected when it comes to service delivery, and then what are your mitigating actions to that? So that's forward facing to our clients. And then the other one I've said, have a look at the back of house kind of things. So have a look at those key activities that will be affected, but our clients may not necessarily see, or our service users may not see. Things like contractual obligations. How do we maintain that? So Elaine, Department of Communities, and our health buddies, hope you're listening in on that one. So we're taking that into consideration and using the planning that you've provided as well. But also what's really important from a sustainability perspective is to have a look at what the revenue implications are as well. So is it a case of, is it a positive implication or is it a negative implication? And make sure you're across that, and then how we're going to respond to that. And then the other important thing as well is from a staffing and workforce impact. We have early learning and development centres and childcare centres here and a hospital on board. So they're likely to be severely impacted with the workforce challenges. So how are we going to respond to that? When the staff have undertaken that as individuals, then we come together. And what's really interesting for us, we have block funded programs and our fee for service programs. For those that have fee for service programs, you might want to really have a good look at what are some of the regulatory things that you can't get across. So with our ELDs or our early learning centres, for example, we've got our ratios, our child to educator ratios, which we can't get across. So how are we going to manage that? And then part of it, then we link back into the organisational thing that we're also doing is a talent audit and a skills audit and a qualifications audit. So if we need to mobilise quickly, which one of our staff have the appropriate qualifications where they can do, where we can mobilise quickly into our ELDs or into our hospital so that we can maintain that service delivery. So that's pretty much it in a nutshell when it comes to the actual service delivery. A key aspect too for me in my role as Head of Operations is to make sure that to the best of my ability, I provide support to my managers. They are the leaders and they're the front facing, they're closest to our staff that are on the front line. Certainly acknowledge in this time of the unknown, people respond differently. Anxiety levels can, go through the roof. Our emotions can dip up and dip down, etc. So I refer to that as wobbling. So I've said to the managers, if you feel the need to wobble, that's okay. There's absolutely no judgment at all from a leadership perspective. However, you are leaders for your team. You don't wobble down. If there's any wobbling, wobble up. And then wobbling up and lean on in each other. And therein comes the beauty of when you've got a really tight team and a trusting team. So this is all the preparation work that you do ahead of time that you won't capture in a business continuity plan is wobble up, not wobble down, because you need to you're steering the ship. So there's that bit of let's make no bones about it. We need to maintain service delivery where possible, but at the same time, be really compassionate to the needs of our staff as well. So talent audit.
Rachel, can I give you a 1 minute warning, heads up?
Absolutely, and we started off with the pivoting in the spirit of efficiency. Now I might buy you back a minute's time for the questions as well. So thank you for the opportunity and for listening.
Thank you.
Thank you, Sue and Beth. That was really clear and much appreciated. Thank you. And I'm sure there'll be lots of questions when we get to question time. I'd now like to invite Kim Brooklyn, CEO of Parkerville Children and Youth Care, who is actually going to address some of the questions that came in following last week's seminar. So hopefully if you had those questions, here are some of the answers and that'll prep you for even more questions, folks. Kim, over to you.
No, chat, they will, Rachel. Good morning, everybody. Goodness me, I'm really sort of a bit bumbly this morning. To recognise that I am meeting today on the land of the Whadjuk, all the great Noongar Nation, and also that we deliver services across Western Australia to recognise other First Nation countries and elders, past, present and emerging. It is nearly the anniversary of the apology, so it's a really good time to reflect on how far we've come and how far we've yet to go, and there's a long way, I believe. All right, so I did do a very pretty presentation, and you will get it in PDF form. And my apologies, it was my lateness. So what I'll do is quickly go through our principles and then launch into the questions that were asked from last week. So our key principles were supporting our people, number one. So we needed to invest in our people to make sure they had the right support, the right information at the right time, the training, the comms, coaching in place. And then what other specific resources could we get in to help them feel safe, supported and able to do their job? So we're recruiting for a nurse at the moment to be our COVID response coordinator, which is quite unusual for this organisation. But the feedback from our team is that they think it will be a really useful resource. The other thing that we've chosen to do is equip our team, and because really the sense of safety is critical to retention. So we've pre-purchased our PPE stocks. We're trying to get about 6 to 8 weeks in advance, including RAT. And I have to say our rats are all over the place, but they're not with us. So they're just so you don't get too excited. We've got some that we ordered at the beginning of January that's still in Brisbane. So I like the fact that they're on the way, but they're certainly nowhere near being here. The other thing is that we need to support our people. So redesigning our services to enhance staff safety and still deliver on outcomes where we can. We're planning for outages and we're planning for closure. And we're also trying to ensure that we can redirect our critical service into our all of our resources into critical service areas. And I'll talk about that a little bit later because there was a great question about that. Recognising the multiple impacts on our team Our team members are mums, they're dads, they're community members, they're way more than just their work role. And so we're trying to help people plan around their self-care. This sector is renowned for being really, really terrible at it. We're very good at giving and supporting others, but we're not so great at doing it for ourselves. And as the stress increases around COVID and Omicron, we think that having those conversations with our team and having a template they complete is really useful. And the ones I've seen so far have been exceptional. And the other thing that we're looking at is systemic and strategic action. So to be honest, in some of our services, particularly looking after children, if we fall because our staffing is an issue, that means there'll be more pressure on government. If government fall because they've got staffing issues, then more pressure on us. So we need to work together. And we need to work together really closely to make sure that the children we're all caring for have that stability and don't, well, we can't not care for them. So we have to find some way to do it. I'm going to go straight into some of the questions. And look, the questions are fantastic, and thank you. We do have a zone system similar to what Brewer talked about. Ours is white, blue, orange and red. And we've got 2 zones at the moment. The Midwest is in white because they have no active community cases, and our Midland and Armidale areas are in blue. And that means that we do different things at different times. The question, and we presented that last week. So the question is, how does Parkerville determine when to move from one zone to another? Public health orders, and really, and also our task force. So we've got a COVID task force, which is made up of some critical team members across our organisation. They make the decision. In some ways, it's a blunt decision because of the numbers are increasing. It'll force us into different zones. But in other ways, it's very nuanced. So if we begin to get low on our PPE stock, I will put everybody at home that can go at home and direct all of our resources to the people that have to work. And it means going into a different zone, so be it, because again, it's around our staff safety. And that's our decision. And we think it's probably the better one because it really is those 24/7 services and our youth homeless services that just can't not operate. So we will redirect our resources. So hopefully that answers that question. How are you going to support people who aren't vaccinated is another question. Do you have any suggestions on how to approach that? We've been identified under the Chief Health Officer's definition of essential and more recently critical service providers because we provide residential care and youth homeless residential care and supported accommodation and a few other things. So that means that our staff were mandated to be vaccinated, and we worked very strongly with our teams for, so that they all met the deadline of the 31st of December. We also worked with a whole bunch of individuals who, for a number of reasons, were unable to be vaccinated. And one in particular comes to mind where there was a medical issue. And so what we did was we put her on leave without pay, put any supports we possibly could around her. And when she can get her vaccination, she will, and she'll come back to work. So we've held her position for her. That's just the right thing to do, to be honest. I don't think it's rocket science. But those ones who said that they would not, for various reasons, be vaccinated, we had to have a different conversation because underneath the mandate, we had to comply. So it's a little bit simpler for this organisation, maybe relative to others. Hopefully, that gives you a bit of an idea of that question. This one, this was a great question. We know that we'll have issues with the award that will restrict our ability to be flexible, long shifts, 3 days on, 4 days off. Any tips on about how to do it without breaching the rules? My first response is that we feel your pain because we do have that issue. We're funded for one person out of home care, and it is a really, really tricky space. So at the moment, we believe there isn't much wriggle room as the industrial instruments are very blunt. They're not designed to be flexible or agile. Despite this, we're doing a number of things to try and prepare. So we've identified staff who will be prepared to work with children and young people who may be COVID positive. We've identified any other staff that with the contractually required checks So some of our services require what is called a 395 check, which is a Department of Communities check to permit that person to work with children. So we're a little bit, we can't just throw in another support worker, for example. That's not contractually not acceptable. So we are trying to find people inside our organisation that also have a 395 check who are not currently working in out-of-home care. We're employing casual staff and getting all the relevant checks in place so that we can ask them to scale up. Hopefully they say yes, to cover a carer should they be off for 7 plus or minus days. We're identifying how we could set up or mobilise our own assets around, we've got some couple of houses we could use if we had to, and maybe care for children who are unwell in those using specialist teams. We're 50-50 on the feasibility of that, given the community spread and also the disruption to the children. So we're not really sure about that one actually. We do already have a buddy house model that we apply because we're in a higher fire zone up in Parkerville. So we've got a buddy house that we can apply for the short term where we can move houses of children around to co-locate with others. We only do that in urgent situations like the recent fires, for example, up in the hills. The kids are great for 5 days, but that's it.
Can I jump in? Sorry, it's Rachel. Can I give you a 1-minute warning? Sorry.
Yep. No dramas. And we're designing a service approach. It's a parallel to the normal service delivery. Now, I'm saying that with massive anxiety about budgets, but we would never actually utilise those unless we absolutely had to, and because we can't disadvantage any of our carers who are in the other service model. So that one is a bit more tricky. If a staff member is delaying vaccination, would you isolate them? We understand that issue, but it's not evident for us. But what we've learned is that all of our clinical work or our specialist work can move offline, and we've worked out that it works quite well, particularly with young people. So it's just how you do that. Again, these slides will be available to everybody. I'm just going to leave it there. I just happy to answer anything other than answer anything and provide you with what our thinking actually is. But I have to say, we, like everybody else, are learning as we go. We had a COVID positive case in one of our staff members who then was converted to a casual contact, but he worked in a very small space, counselling rooms. And so we decided to put that into a telehealth immediately to protect himself and others potentially while he went through his testing. So you kind of have to be a little bit agile, even though you might have some ideas about what is right and what is the best way to go. Hopefully that answers something, and hand it back to you, Rachel.
Thanks, Kim. Really appreciate it. And hopefully people that asked those questions last week heard them, but also others got a lot out of what you've just articulated as well. I'd now like to hand over to Louise Gilletto, who from WACOS, obviously, CEO of WACOS, who first off is going to outline just a little bit of the work that we've been doing on workforce, and also then moderate the questions that have been coming in.
Thanks very much, Rachel, and thanks everybody for joining us again today, and especially the organisations that are so willing to prepare and share the information with other organisations. I also want to acknowledge the organisations that have spoken this week and last week are larger organisations, and they acknowledge that themselves, so they have a bit more resource to actually put this stuff together. And all through COVID, so the past 2 years from doing mandates, policies, on WACOS's website, we've been sharing this information that's been very generously shared from the larger organisations, because we really do mean it when we say we're in this together, and knowing there's different capacities and capabilities within the sector. I mean, I'm not sure how many staff Rural or Parkerville or Nagala have, but I know there's little tiny organisations with only 4 or 5 staff. So that's why they're so willing to share. Because all this information that is being shared, and I'm not being over dramatic, it will save lives. It actually has come up through all the presentations. There's this real fear around surge workforce. We have learnt from the eastern states at their worst, say in Victoria, the Victorian Anglicare, they lost about 25% of their staff, but that was when they had to have quarantine for 2 weeks. So they've already said it's improved once that quarantine came down to 5 days. Really good news, a week ago it's coming down to 7, and it's safe to do so. So we'll know if your staff have to quarantine for 7 days. I think the announcement is they will, they'll be provided RAT tests, and they'll test themselves, any member of the public, on day 7 if they're free and they can come back to work. And we also know for a lot of people who may have to quarantine may not feel ill, therefore will still be working, but will be working remotely as well. So it's not the case that everyone, even though they're in quarantine, their willingness to work will still be there if they're capable of doing so. We also know that this issue of surge workforce will really vary. We're really hoping we don't get to the levels they did in the eastern states. I mean, our controls in this state are already much higher. If you think about Sydney, they got to about 10,000 cases per day before people were required to wear masks. We're not doing that in WA, so we're really hoping we don't get to those numbers. So we're looking at states like, I think a more accurate is like South Australia and Queensland, and where they've actually got than Sydney and Victoria. But the issue of surge workforce continues. Earlier this week, and we're in conversations with ministers and the Department of Communities on this issue. So WACOS is doing a bit of preparation around this, and you will get an email next week. We've met with some of our members, and we've designed some principles of how that could actually look, which is not the hard part. The hard part is the how. But what we'll be doing next week is we'll be sending out the principles through our network and our newsletter, asking people what they think, and then asking if people want to buy into this. But one of the critical things in this is when we actually look at this, the difference between critical and essential. So there's a lot of essential workers out there. I think I'm essential, but I'm not critical. I'm not on the front line. So, I clearly don't define myself as a critical worker, but a woman working, a frontline worker working in a women's refuge is a critical worker. So this is the ability for us to design a secondment pool where people can move between agencies so that critical service continues. That it's absolutely, and if you think of the state emergency response, that is actually threatening to someone's, physiological well-being if that service doesn't actually continue. We've heard from government that there isn't a cavalry of staff on the hill that's going to come rushing in to save you, because Department of Communities is in the same position as us, that there was already a staffing shortage. So please stay tuned. We are doing work on that and scoping out the possibility. And again, really important, we don't expect a small organisation will be able to provide staff to come in, like if they're running a small home, it's like a one homeless service. However, the larger organisations may be able to send staff in for 3 or 4 days to assist you. So we're putting some realistic expectations around this. So I just wanted to put that out there. Some work is being done. So I think there was somebody who was going to read out the questions, and because we've got a few, and then I was going to throw them over. So somebody in Department of Communities, were you going to read out the questions?
I just got a message for you to read them out, if that's possible.
Okay, I can actually group them, and I have actually been looking at them. There was a question, and this is questions been often asked about unvaccinated clients. So in relation to, Kim responded in some respect to having our staff having to be vaccinated, and the Chief Health Officer's made it really clear the mandate does not cover clients. So that's super clear, but some organisations are still questioning, will they provide those services face-to-face to clients? And it's different in each situation. So I'm going to ask Deb and to answer that question, like how's RUA managing vaccinated and unvaccinated clients?
So I think that I always sort of take my lead from healthcare. So no unvaccinated patient would be refused treatment in a health setting, and I think we have to take the same view. Obviously, we ensure that our staff are vaccinated, that if we know the vaccination status of a client, that we wear the appropriate PPE, use the precautions and safety standards that we've been drilling into ourselves for the last 2 years, social distance, all of those things would be in place. So I think, and if I take, for example, the population group of rough sleepers, I'm pretty sure everyone's sick of me speaking about rough sleepers, but I'm obviously still highly concerned about this group of people who have the lowest vaccination rates because they got nowhere to recover from a vaccine. And yet they will be some of the most vulnerable people because of their comorbidities. We would not stop providing services. So remember where we've been vaccinated, we've got a 100% vaccinated workforce, we've got PPE, we know how to safely apply it, so services continue.
Does anybody else want to actually add to that? Because I also know, depending on the service type, so say for financial counselling, they may have pushed, if you're unvaccinated, they will do that online if there's the capability, but they're not being turned away at an FDV or a homeless service. And I think this is where RATs will become really important. When unvaccinated clients come in, you can isolate them for 10 or 15 minutes to see if they've got COVID. Kim.
We're assuming, particularly in our very high risk services, and that's the services that go out with the police or our youth homelessness, there's a lot of movement into the community. We're talking about assuming everyone's positive so that our staff then think about their PPE from the very start. And I think that's the only way that we really can try and enhance the safety of our team. Knowing that you don't know, we have no control over those people that are coming into the service.
Lou, can I just add, because I think that's such a critical point, and that's always been the rationale behind what we call standard precautions or universal precautions. You assume people are positive or they've got TB or they've got whatever, or bloodborne diseases. You make that assumption and apply the standard rather than trying to individually find out if people are affected. Obviously, in congregate living, there is slight adjustments to that. So I really think that's a key principle. We assume positivity and we apply the standards. Els, did I get that right? That's my nurse.
Yeah, that's absolutely right. And I think, looking at, where can we do things outside where there's maximising ventilation, keep our distance. Yeah, assuming, definitely, we wear PPE, assuming that people have the virus.
And Sue here from Nagala couldn't echo the sentiments of Deb, Kim and Elsie as much as well. So I absolutely.
And I think I know that there's a real anxiousness about staff, but them themselves being vaccinated is providing them a high level of protection of hopefully not getting it, but not getting that ill as well. And I think we actually have to remind staff of that. And there's other things like I always think of a woman fleeing family and domestic violence and being turned away from a refuge because she's not vaccinated, and that's life-threatening in itself. So I think that's that constant message to staff as well. That's why you are vaccinated. I'll go to the next question, and it's in relation, and this is in relation to FDV, and I think it's more of a question for Health and Department of Communities. It's a really important one, that if a lot of family domestic violence services, well, all of them, the women's refuges, they're not advertised. And there's a fear that if they get listed as an exposure site, so how is that going to be managed, and the assurity that can be given to women's refuges, they're not going to be listed as exposure sites?
So maybe if I can just start, and Elaine might want to add. I know the FDV sector has some very unique challenges, and we are working with the Centre for Women's Safety and Wellbeing, and I think we are organising some sort of meeting next week to try and thrash through some of those issues. But that's actually that one hasn't been raised to me, so that's a really good opportunity for us to really think about that before we respond next week. Deb, I see you've got your hand up. Is it something within RUA that you're managing?
Well, I think it's a really good question, and I think one of the things a step before that, while you guys work that out, is the team A and Bs, and to stop cross contamination of our refuge sites. So limit any external visitation into those sites, given that we're in amber and we've got some community transmission. Given the greater risks associated around FDV, I would be saying we should go earlier on some of those positions, like limiting contact in, not crossing, if you've got more than one refuge, not cross-contaminating staff as a preventative thing before you guys decide, which the whole issue around if someone's positive and how you make that known.
But definitely the query around addresses is going to be challenging, so we'll take that offline. Is there anything you want to add, Elaine?
I think that would be the main thing. We need to be doing some work with the Department of Health, because we're making decisions about what gets included as exposure sites and what doesn't. So we definitely need to be doing some work with them on that.
The person who asked the questions gave the solution as well, because someone's home doesn't get listed as an exposure site, and they need to be treated in because it's people's homes. So that's got to be really clear. So thanks for the question from the person, because you also gave the solution. We've just got to make sure that happens. The question is about, does anyone know, so this is Department of Communities, because I don't think the community service providers will know, about the status of the online register for critical workers, because we know, when will that be released, and is there any information about the type of information we're going to have to list, or service providers will have to list? Will it be every employee, or they group, like we've got 7 people who work frontline in homelessness service? Info, please.
Yeah, so I mean, I can say that this is all being, this is a piece of work that Department of Premier and Cabinet and other agencies are dealing with. So communities are just being kept informed, and we understand that there'll be announcements about that imminently. I think given the current spread of Omicron, I think it's going to be sooner rather than later, but I think there's a lot of work being done at the moment around that register and trying to get out some comms to the sector about what that's going to look like. So I can't, obviously, it's really a DPC announcement, but I understand that they are absolutely cognizant of the urgency of it.
There's another question here, and it's from Regional WA. It's Miranda, she's put a name up. It said they're finding it already really difficult to provide support services for vulnerable households, to getting groceries to them, but also that, you know, they've may have been to an exposure site to actually get tested, the availability of RAT tests, etc. So in preparing and supporting, just say they have a household that has COVID, there's got nobody who's going to do the shopping, get food supplies to them. What level of support will there be there for those households? So again, that's a government question.
Yeah, I think that's a very good question. It's not one that we probably have a solid answer for right now. I think that's a piece of work that really is some discussions that need to happen. I know there were some issues raised over East, particularly about some families, for example, where mum and dad both were sick and ended up in hospital. What would happen to the children and stuff like that. So those conversations are happening, but there's not a kind of solid, this is exactly what will happen yet. Again, I think that will be affected by workforce issues and all that kind of stuff as well, because we could say yes, we could put out and then see could we try and find the support, but again, if it's in the middle of a peak outbreak, some of that issues are going to have to be worked through.
And Louise, we can also speak to SWIC and get a response from SWIC.
Absolutely, yeah.
So can we just take that on notice, and we'll come back to you guys.
And I've got a bit of an answer here myself, and I'm going to say for that person, or that Miranda, I would actually be ringing the 1326 843 COVID hotline if you've got clients in desperate need already. The state government has actually set that up to actually help people, and if people don't use it, we won't actually know the scope of the issue as well. So that's part of the solution. I know it's not going to answer it, and it kind of ties into the next question. Overcrowding is a significant issue we know in regional WA. Like in the Headland, for example, we could have 24 Aboriginal people living in one home, and there could be an outbreak in that home, and what would actually happen. Now, this is my understanding, and other providers, please jump in if I actually got this wrong. Firstly, it's a health response. So health department need to be contacted. And in a situation like that, I've been informed that what then would happen is they would determine if it then becomes a state emergency, like a SWIC response, and the SWIC's responsible for accommodation, health and wellbeing, and they then need to respond at a regional level, the support they will provide around that family. So there is a bit of a tree of sort of how the decisions are actually made, but firstly, it's always starting with health. And then from health, you would then push it, and the health then decide and pass it on to the Department of Communities in relation to the level of support. And there is teams set up in each one of the regional areas, in regional teams, looking about how they would respond. some of this is obviously going to determine on capacity. So if there's only a couple of outbreaks in Headland, we would imagine that, you know, there would be quite a quick response. But if they're dealing with like 40, it's going to be different. So this will be a watch and learn, that everyone should have that telephone number, 13 26 843 is the COVID helpline, where you would take these queries and really because we're relying on the community service sector providers to really advocate on the behalf of your members and to push it. I would also suggest, if you would like, to send that sort of circumstance through to WACOS, and I'll take it up because WACOS coordinates the emergency and food response. So I can take it up through there as well and connect with the whole network from food bank to little to small big providers and see if there's a solution for that particular town you actually have at the moment, Miranda. Sorry, it's not a perfect answer, but that's where I would start. So we've done the overcrowd. Can anybody add to the overcrowding issue for, you know, like any of the homelessness services, of any plans that you have, some of the clients you're dealing with?
Sorry, can I just add, Louise, that that's again a role for SWIC. So if a state of emergency is declared, and say in this scenario that might be the case, then SWIC is then mobilised to try and support those individuals, and it might mean that they have to find accommodation for some members of that household, but they'll be working very much and guided by health.
Yeah, so that's, as I say, I can't stress enough, health is always the first entry point when there's an outbreak, even in a household, and that household needs support, and then then there's a decision tree. That was the word I was looking for. There's a question from Jane, anonymous. So this is to the organisation. What supports are organisations planning on implementing if clients do not have reliable internet connection to access services online? So any of the service providers? Kim, you were nodding your head.
Yeah, we've had that with, we had that last time. We begged, borrowed and stealed. Secondhand laptops. We just had whatever we could find to help. We had purchased a whole bunch of very cheap mobile phones, particularly for the young people, where retaining their phones when they were couch surfing was not always easy for them to do. And we'll probably do exactly the same thing again, because the connection is critical to their well-being, and the connection is critical to our teams to enable them to get food and a whole bunch of other things. So we know that that's a cost, and we love our donors. We love our donors. We love our donors. Is all I can say.
Anybody else had a solution, Sue?
Yeah, no, we don't have a solution because we weren't actually confronted by the issue. So when we've gone into lockdown previously, we've actually asked and sought the readiness, I suppose, of service users and what their situations were. So we weren't actually confronted. We'd asked the question, but then didn't need to respond because there was no issue for us. We might have a different demographic though, because the services that we provide aren't necessary to those that are experiencing homelessness or who aren't in that position.
I think for us, so in the last time we purchased a whole bunch of mobile phones, and particularly for family and domestic violence, that couldn't be women not using their own phones, but also for some of our street present people, tablets or laptops that we're replacing. We keep the old ones and use those as well. And some of the companies, donated some stuff. So it really, I think it's a really important question that those, and also sometimes using emergency relief to pay people's internet access, which is really critical because it's their only point of connection, particularly in the mental health space where isolation and depression and anxiety is really critical. So I'd be encouraging us to be using ER in that space.
Can I just add one thing that just did come to mind? One of our programs, which we could change our method of delivery, is something called PAL, or Parents and Learning, which is primarily a reading program where parents read to their children. So what we've got ready to go is to drop those packs off at their parents' letterboxes, for example, so that there's limited contact for those that may not have access to any other services. So that's a way. It applies in some situations, not in all situations though.
Thank you. And Deb, you took the words out of my mouth. The emergency relief is a really important thing because internet and phone use is actually now regarded as an essential service. So through WA Connect, it's on the WACOS's website, that provides a list of all the food and emergency relief providers that are out there, and you could be making contact and trying to connect through WA Connect to where you can actually get that support. I'm not guaranteeing it's going to be there, but as an advocate for your clients, I would sort of request that you actually do that, and maybe purchasing some phone cards, etc. yourself. Kim, you were going to say something else?
Yeah, I was actually going to say for people just to do some scanning around some of the grants that will be available. We did get a small grant from a local government where we're supporting a lot of young people that gave us a $5,000. But that $5,000 enabled us to buy a whole bunch of phones, and there are small pockets of money. It's just you have to watch out for them. Yakwa will help people who, particularly in the youth sector, identify some of those areas, but also again, look at local government. Sometimes they do come out with those grants.
Mm-hmm. The next question is a really interesting question from Jane. How are services managing difficult behaviour in relation to mask wearing, checking in where appropriate, providing proof of vaccination? Many of our members are dealing with significant conflict from community in relation to these mandates. And we know there's certain areas in regional WA, again, where it's more prevalent that people aren't vaccinated. We've got very low vaccination rates in, say, the Pilbara, for example, and, well, not really low, lower in the Pilbara, etc. So what's your experience, the service providers, Kim or Deb or Elise?
Yeah, I think we've definitely seen that challenge in our service. In terms of mask compliance has been a really big one. So, the first step is, reminding people to wear it and reminding them, how important it is. But the reality of, if that's not working, we've looked at what can we do to make sure that we're complying with the mandate. So it may be that we need to have, rooms that are different, or increase the social distancing. And, if it comes to it, limiting the number of people in one time at a service. In our Safe Night space, we've recently looked at, the reality of people wearing a mask while they're sleeping in a congregate living, like in a big shared room. We called the COVID hotline to kind of test the thinking and as a bit of experience. And, the messaging was that we have to wear masks at night when we're sleeping. And you can imagine the compliance for that, even if you're not aware of it, you take your mask off. So yeah, we're working through those challenges. I definitely don't have the perfect answer for it, but we're daily talking about how we can do it and what we can do in shared settings where we've got a big open room with kind of 40 people in it at one time and more, and how we manage it. So yeah, keen for ideas as well if everyone's got them, because we're experiencing that challenge as well.
And I can't just add to that. I think this, Elsie and I have had this argument. The COVID hotline told us that they have to wear masks while they're sleeping at night. My view is they don't. You can't, and patients don't wear masks in hospitals at night. So I think part of it, from the department's feedback to SHIC perhaps, whilst that might be fine in theory, but when you've got 40 women or 20 women sleeping in a safe night space at night, that's not realistic. So I think we've been pushing back a little bit in some of those areas of advice.
Because they're not singing or dancing while they're sleeping. Kim?
No, they're not. But again, it's about how do you protect your staff. So if they've got the right equipment, they are as safe as they possibly can be in that instance. We've been fortunate to not have that as a big difficulty yet, but I suspect we will. And again, it's about how you protect your team and then how the team then models some of those behaviours. And it doesn't even really have to be that aggressive at all in terms of policing a particular policy position. I think it's about, I think Deb's right. I think you have to be deeply respectful to the people you serve, and there's no way our young people would actually wear a mask if they go to bed. I think they'd be telling us the few choice words where to go.
Thank you.
Yeah, and Sue here, we did quite a bit of preparatory work as well. So particularly through in terms of sharing what the expectations were about entering any of our premises, engaging with the services. So we did that through through some of our closed Facebook groups, etc. Did a lot of work with our staff as well in how to respectfully remind people to put on their masks. So it goes back to what Kim was saying. So we haven't been confronted with that behaviour. We also have regularly our Work Health and Safety Committee meets, so we ask that question to see, you know, what is happening out in the community. We just haven't been confronted with it yet.
There's a question here, I think it's in relation to extensive cleaning. If there is a positive case, will this not affect continuation of critical services? So from any of the service providers, because I know deep cleaning is no longer the buzzword. So what's your policy? You've had a positive case in maybe a residential service. So how does that affect your cleaning regime?
One of our continuity plans for our houses is that if there's a positive case, there's increased cleaning by a contractor, because we can't expect the carers to be able to do that level of cleaning all the time, look after the children and do those levels of cleaning. If there's a positive cases inside the house, to be honest, it's just the cleaners come in and do their business. We can't shut that down. Where in other areas we will just increase our, we've shared the responsibility with our teams for the low level cleaning with daily wipes of all their spaces. And then we've increased our cleaning from contractors to a higher level as well. So it's a bit of a, I guess, a stacked model with as much resource as possible going into the people who are looking after the kids or looking after the young people.
Thank you. Did anybody else want to add to the changes in cleaning regime, Sue?
Yes,
Yeah, Beth will respond to that one.
yeah. So not dissimilar to what you mentioned, we are calling it post-incident cleaning now, if and when a positive case, and we would also be bringing in a contract cleaner just to make sure that we were able to meet the required elements. Otherwise, our general cleaning has already, if you like, been upped as per last year when we needed to know that those community cases. So, yeah.
And I think the Department of Health is updating the information in relation to cleaning, and that information should come out very soon. Deb, did you want to add anything?
I think that for the centre, if we, there would be a scenario if we did have multiple, or we realised there was a positive case in a shared space, that we would need to have a deep clean, and that may mean that the service is shut for a morning or until we can get that clean done. I think with everyone in open space, we need to make sure that we've done really good cleaning.
The next question is, we're going back to the unvaccinated clients. It comes from Karen. Another potential of a legal action being taken against an organisation by the staff member who contracted COVID from an unvaccinated client. So this Karen, they've moved a lot of their services to telehealth and online to protect their staff. So they're obviously a service where they can do that. Does anybody have an opinion about staff taking legal action about contracting COVID? I mean, this is one of the issues that I keep hearing. Elise?
It's a highly mixed one, Louise, isn't it, really? Because how do you identify where that person contracted COVID from? I think the lawyers will be having a field day on just that concept alone, to be honest. And because I think one of our biggest risks is our staff moving in their normal lives and bringing COVID into our site. So unintentionally, of course, I don't do it on purpose, but I think it's just such a, I think there's going to be a couple of test cases about this, is my sense.
And I think I would add to that, I think Kim's absolutely right. I think we just come back to first order principles, duty of care. What have we done in our duty of care to maximise and to ensure that we've protected our staff as much as we absolutely can? I think the focus has got to be off whether a staff member individually takes legal action. I don't think you can answer that question. I think the question is, from an employer's perspective, have I maximised all my responsibilities under the legislation and as duty of care? I think that's perhaps a more pertinent question.
I think what we've seen in our teams is the importance of supporting people to remember that PPE and the basic measures do work. So, my experience as a nurse working with people who are always infectious potentially is that we know that the basic principles work. We know that if we're socially distancing, wearing a face shield, wearing a mask, it works. And I'd be comfortable working with someone who's COVID positive if I'm doing all those things. And I think just reinforcing to staff that we've got all the measures plus vaccination, and that we know it works. And in hospital settings, people are working with COVID positive people all the time, and they don't contract COVID in every case if they've got PPE.
Thank you. And I think also, like, there may be some cases that actually emerge, but this is that whole point about living with COVID. And that doesn't mean they don't exist, but you think of the number of cases that have happened over East, and I'm still not hearing of any cases actually emerging yet. So I think, you know, the risk, we can get a bit stuck on the what ifs, and there's a very small percentage, and then we actually stop services to actual vital people. There's a question here.
We've got time for one more question.
Okay. Oh God, I'm going to have to be choosy because there's a few left. There is a very small not-for-profit who takes donations on laptops. No, that's not a question. Oh, this is the last one. It's a 24/7 question. And again, it's for a detox sobering up service that we will need to operate for 24/7. How do we deal with unvaccinated clients who want to avail our services? So I think we've answered that to some respect. And I think I'm also going to say, one of the measures that will be put in place, and if you're a 24/7 and they're not leaving the service and they're not moving around in the community, and all your staff are vaccinated, and I think this will be when RAT tests come in, that there might be, like, when someone's coming into a 24/7, any residential setting, I'm hearing lots of services, that's how they'll use RAT tests. So they have some level of surety when they come in, it will be okay. Because you could have a vaccinated person coming in who still has COVID. So it works both ways. So any other comments from any of our other panel members on that one?
I think it's the same thing we mentioned earlier, is we assume people are positive regardless of their status. First principle, I think.
Sue?
Yeah, no further comment.
Okay, I've run out of time, so back to you, Rachel.
Thank you, Louise. Thank you to all our panellists. We really appreciate your time. There's so much to take out of what you've said, so it's really hard to summarise, but I liked the comments around, and I think these are really important to remember, to consistency across your organisation. Be flexible, have your plans that are flexible, achievable and sustainable, and be ready to change direction if you need to. And also very, very key is working with your staff, looking after your staff, making sure they're informed and involved as far as possible, and making sure they're well and looked after. There'll be more information soon on the surge workforce issues that Louise mentioned earlier. We'll be in contact on that as soon as possible. So I'd like to thank everybody, all our panellists. Thank you. I would like to, if people can let us know how they feel about the more interactive session, if that's been helpful. Thank you to the participants. Sorry, I'm coming through somewhere else. I've been asked to remind people that if you have any questions, please email sectorsupport@communities.wa.org.au. And now I'm going to throw back to Bev, who has a couple of other messages for people.
Great, thank you, Rachel, and thank you again to all the presenters. Certainly on behalf of Communities, it's been really helpful for us as well, because it really informs our conversations out, because we do get quite a lot of questions through the sector support email address, so it's really helpful for us to be able to give back feedback, which is great. I just wanted to let everyone know too that we are regularly meeting with the peaks now. We're trying to set up a weekly meeting. We had the first of those yesterday. So if you do have other queries and questions, we do encourage you to raise them through the peaks, and we can try and address those on a reasonably quick basis. And as Rachel's alluded to, that on the screen there, you should see the sector support email address. If you've got queries, we can try and field responses where we can. I just wanted to have a quick conversation. One of the things that was raised yesterday was the issue of PPE and what the guidelines are, and I guess whether there's some good information around about how to use PPE. My understanding is that the Chief Health Officer is, as we speak, putting together some more reviewed guidelines. So as soon as they're available, we'll be distributing those. But I think the Chair's recognised that there's a lot of confusion in the community about the use of PPE and what should be used in what situation. So I understand that's being developed, so we'll share that. I know RATs is a big issue for the sector and it keeps coming up. While I'm not able to provide a direct response, that will come from the Department of Premier and Cabinet. There is work being done behind the scenes across government around the community services sector. So just to advise that I'm hoping that there's an imminent announcement about that, but that's not something I can message out. That really will come from the Department of Premier and Cabinet. And also I just want to quickly thank the team at Communities. This always looks it's quite smooth, but it's actually a really huge task to put together a webinar and make sure that we've got all the tech in place and all the slides and that we've registered people and so on and so on. So I just want to say a huge thank you to the team. They are behind the scenes, but they are people who, without their support, we just couldn't do this. So just wanted to thank them individually for doing this for us. So thanks, Rachel. I'll just quickly throw back to you to say farewell. Thanks, everyone. Hope you have a great weekend.
Thanks, Bev. And I think that's a really good point to finish on. And that is the example of where we have to work in partnership with government agencies on this issue. And the more we can work together, I think the better results that we're going to have. So thank you very much for the support for the webinars and also the numerous and innumerable meetings and working groups that you are participating in with the community sector. Thank you very much. Once again, thank you to our panelists and speakers. Very much appreciated. Let us know if you want more webinars on what particular issues or other ways that we can be of assistance. Thank you very much for everyone for your time today.